Hello and welcome everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own tumor defeater, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers to access the right treatment at the right time. As life expectancy rises and global population ages, more and more elderly individuals are being diagnosed with cancer today. There are unique challenges, decisions, and considerations from managing other health conditions to balancing the quality of life in these elderly cancer patients with effective cancer treatments. So, would treating cancer in elderly be the same as treating cancer in younger adults? This is our topic for today. Let us find out in today's session on geriatric oncology. Without much further ado, let me begin by introducing our doctor. Dr. Krishnamani has been a key figure at AOI Hospitals, Hyderabad for over a decade, where he brings extensive expertise in managing solid tumors, hematological malignancies, and oncological emergencies. Throughout his career, he has held pivotal roles in leading cancer centers across India, earning a reputation as one of the nation's most trusted and respected oncologists. In addition to his clinical excellence, he has been actively involved in shaping cancer care policies and treatment protocols. His contributions to clinical research are reflected in his advisory roles and involvement with multidisciplinary tumor boards. A strong advocate for continuous learning, he frequently engages in academic discussions and knowledge sharing platforms. Hello and welcome to you, sir.
Hello, welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. And as you said today, let's talk a little about treating cancers in the elderly.
Yes. So, sir, can you please specify what exactly is geriatric oncology? Is it based only on the age of the patient? Is that the only parameter?
That is the parameter. Geriatrics is as a department means people who are above the age of 70. So you're talking about that particular population. A young man may not be fit clinically, but he will not obviously be a geriatric person, right? He's young age-wise. So, and also what we should understand is cancers are often a disease which we see in the older population. As you grow old, age is an important risk factor for development of cancer. So the longer you live, the higher the chance of developing cancer. So, uh, and it becomes difficult to treat the elderly because the general condition is as you grow old, your joints are weak, your heart gets weaker, your lungs are probably weak, your energy levels are low, cancer treatments are toxic. You may not be able to tolerate it the way a 40-year-old or a 30-year-old tolerates. So the bottom line is, though we see a lot of cancers in the young, cancer is still a disease which is seen predominantly in the older population. As you grow old, there is an increased risk of cancer. And we should be fully aware of how to treat these cancers in this population because this is a different population. They will not respond like a conventional young, fit guy. And also in your clinical trials, mind you, in your in all our clinical trials, which we consider as a reference to treat our people, majority of the people are between the ages of 18 to 65. So 68 years, 72 years, 80 years, what you see in the clinic, those patients are not represented in the clinical trials also. So you cannot extrapolate that data exactly 100%. So in clinical trials also, they take patients very strictly in that age group who are extremely fit. And in the daily life, you don't see such elderly people who are fit, who are super healthy. So that's why geriatric oncology is a challenge, and that's why we should know more about it.
So, can you start by explaining which cancers are most frequently seen in that particular age group only?
Prostate cancer is a disease of the elderly. Very, I will not say rarely, but uncommon to see people below 40 developing prostate cancer. Okay. Next comes to which are the common cancers? Your breast cancer. Breast cancer is also seen in patients above 60 or 70, but we see a very good amount of breast cancers in the young. Lung cancer is again a disease attributed to smoking, cigarette smoking, or BD, tobacco smoking. And the more the years you smoke, obviously, the more the chance of developing lung cancer later, and that also develops in the elderly. So on and so forth. Stomach cancers are seen in patients above 60 and 70, gallbladder and cholangiocarcinomas. So most cancers, as endometrial cancers, are just generally seen in post-menopausal women. So women after menopause, that after the ages of 50 or 55. So cancers are predominantly, especially prostate, endometrium, the GI, genitourinary cancers, the gastrointestinal cancers are seen in elderly.
Would you say that these cancers are more aggressive in nature as compared to that found in younger adults?
No, it's actually the converse. Cancers, again, you cannot take it as a dictum, but generally, if you see, yeah, cancers in young are a bit aggressive. But there are a lot of factors to define which is more aggressive. Like you may be presenting with symptoms for a very long time, so you have more volume of disease. So a person has not gone to hospital, is not got himself checked, but he's just suffering with the ailment. Once he goes to hospital, obviously he'll have a large amount of disease, so he will do badly. Somebody who's extremely poor will do badly. So poor general health, I mean, uh, somebody who's extremely elderly and poor general health, somebody who has multiple background issues like maybe a cardiac issue, a lung issue, a liver issue is going to do badly. Then there are tumor factors, the grade of the tumor, the stage of the tumor, the we call something called Ki-67. The higher the Ki-67, the higher is the doubling of the tumor. Higher is the growth rate, rather, growth rate of the tumor. So high Ki-67 means faster growth rate. Those cancers are more aggressive. So all these factors add up, but generally cancers in the young are considered more aggressive.
Would you say that cancers in the elderly population will be diagnosed in the same way? Like, for example, a 39-year-old with prostate cancer and a 60-year-old with prostate cancer. Would the diagnostic tests be same for both the age groups?
Yes, you will do a PSA test, you will do a biopsy to confirm, you will do a PSMA scan to see if it has spread or not. Only the treatments will differ. A 39-year-old fellow can probably take chemotherapy with docetaxel. An 80-year-old man may be unfit for docetaxel. If you give him chemotherapy with docetaxel, he may have a lot of trouble, maybe in the form of fallen WBC count, infections, chemotoxicities, vomitings, etc. So for him, you will choose some other tablets like abiraterone, etc. So evaluation is the same for any cancer across the age group, but treatments will differ.
So, when we talk, since you have already highlighted about the diagnosis, which is going to remain the same irrespective of the age of the patient, when we talk about the treatment planning, age will be a big factor in deciding the treatment for the patient. And
Correct.
what about the other comorbid conditions as well?
Age is a big factor, gender is a factor, your comorbidities. What are comorbidities? What all problems you have? How is your heart? Are you a bypass patient? Do you have a stent inside? Have you had a heart attack before? Have you had liver failure before? Is your lungs okay? Because of smoking, have you damaged your lungs, called COPD? Okay. Are your kidneys fine, or are you a chronic kidney disease patient on dialysis? So all these comorbidities, do you have seizures? So your comorbidities, your age, your fitness, general condition, everything matters before you start deciding on treatment.
So, can you give us an example of how these conditions affect the cancer treatment decisions that you need to make in clinic?
Now let's take breast cancer. Okay. Now we have a 80-year-old with breast cancer. Imagine she has a 5 centimeter breast lump and she has a lymph node in the armpit. So ideally for such a patient, what will you do? You will check hormone positive ER, HER2 status. But most likely, if it was a young woman, you will first give chemo, shrink the disease, and then send for surgery. Here, if at 80, suppose her general condition is very frail and poor, and if she's hormone positive and HER2 negative, you will directly send her for surgery, maybe. Only if she's HER2, suppose if she's HER2 positive, you may probably not give chemo. You may probably only give targeted therapy if she is not fit for chemo, or you will give weekly chemotherapy rather than 3 weekly chemo. So 3 weekly chemo in younger fit people, but elderly you will give weekly chemo. If it is hormone positive in a young person, you will give chemo and go ahead. If it is a big tumor with lymph nodes, but in an elderly, you may say you are not going to tolerate. You are hormone positive. It's a good disease. I will take you up for surgery upfront. Okay, so that is the way it will differ. Whether it is surgery, whether it is chemotherapy. So if it's an elderly 75-year-old lady with 2 or 3 lymph nodes positive in the breast, you will avoid radiation after surgery. So you cut a lot of slack. Now, in a lung cancer, the other day we had a gentleman, he had a large lesion in the lower part of the left lung. It had not spread anywhere. Ideally, what you should do a mediastinal evaluation. That is, you should go into the mediastinum, the place between the two lungs here, look for lymph nodes, see if it is stage 3 or not, then give radiation plus chemotherapy. If it has not spread anywhere, you should go for surgery here. So you should do mediastinal evaluation. If lymph nodes are positive, you give radiation. If lymph nodes are negative, you will do surgery. Will this man tolerate surgery to the lung? Can you remove half of the lung at age of 85? So for him, we gave only radiation. Will he tolerate chemotherapy? He was too thin and frail to tolerate chemotherapy. Now today, we had an elderly lady. She's more than 90 years. So apparently she comes with a stomach cancer. Okay, scan wise, it has not spread anywhere. So I should do an endoscopy. I should do a biopsy. Biopsy has come as stomach cancer, signet ring carcinoma, which is very aggressive. Ideally, she needs proper staging. We should do a laparoscopy. Okay, we should look inside her abdomen whether she has any disease. If no disease is there, we should give 4 chemos first, highly intensive chemos every 2 weeks for 2 months, and then take her up for surgery, which is a very big surgery. Can I do that in 93 years, 95 years? Chemos, surgery, general anesthesia, and overall, it's a bad disease. So, what are you going to do there? Really, nothing. You don't have much options because if you do any of this, she will end up in ICU after that. And your treatment will give you more toxicity and it will kill her. So, for her, you should say best supportive care. Be happy, be comfortable, wherever, whatever symptoms you have, we will treat those symptoms. So, that is what we should understand. So, in elderly, sometimes you may not be able to treat. What you need to do is only supportive care, or TLC, we call tender loving care. So just because somebody has a diagnosis of cancer doesn't mean you have to run and jump and treat them at that age, because your treatment will cause more harm. So you should know whom not to treat. Not only whom to treat, but whom not to treat.
Do you also practice dose reductions in elderly patients for chemotherapy?
Should be done. In a stage 4 palliative setting, there is no point in giving full dose and pushing your patient to ICU or killing that person. Rather, give a reduced dose, because your aim is quality of life and prolonging life with little suffering. So elderly people will require dose reduction. If you don't do in the first cycle, you'll be forced to do it in the second or third cycle. But elderly people who are fit, whose organ function is good, who have a curable disease, you please go ahead with your proper dose if you feel they will tolerate.
So, sir, how do you gauge if a person will be able to tolerate a full dose or no? Do you have any specific geriatric assessment tools
Yes, yes.
of such
Nowadays, there
sort?
are geriatric assessment tools available, online calculators available based on the age, the fitness, the bone marrow reserve, the WBC count, the platelet counts, etc. And all these give you an assessment on how the patient will probably do. But more or less, after you give one cycle, you get a indication on how this patient has done. If somebody has done very poorly with lot of vomiting, with lot of complications, severe fall in the WBC count, then next time you have to reduce the dose. Another patient has just had some hiccups like nausea, hair fall, and all that, but by and large, that patient is fine. Then you can treat him appropriately, full dose.
So, what does the current research say about immunotherapy or targeted therapy in elderly individuals?
You can treat them the same way as youngsters if their general condition is fine. There's nothing like that.
Okay. So, like, normally you give nutritional advice to your cancer patients, to younger adult cancer patients. You tell them to maintain a healthy lifestyle. Do you pass on the same information for your elderly patients as well?
Yes.
Exercising.
Correct. Eat well, home food, less spice, less masala and chaat items and all that are outside food, small frequent meals, balanced diet, lots of portions of fruits and green vegetables and fruit juices, those kind of things. A little bit of exercise, 20, 30-minute walk if they can every day, at least even a 15-minute walk, fresh air, that's all, and be around good people.
So when you suggest patients go for palliative care, what kind of rehabilitation or recovery do you suggest these? Do you expect these things from your elderly patients as well after palliative treatment? Say,
See, rehabilitation means see, that's a whole big topic, right? Palliative care, hospice care, end of life care, and then rehab. They are all multiple different things. So, if you are at end of life care, what does it mean? It's a matter of few hours or days or something. The patient needs to be comfortable and without pain and suffering. Palliative care is one step, probably. It also includes that. But again, the emphasis is on quality of life. Rehab and all that means you'll be given physiotherapy support, you'll be given breathing exercises, those kind of things, so that you are on your feet at least with or without support.
how can families support elderly patients who are going through cancer?
Stay with them, understand their problems, understand that they are different, understand that their mindset is also different, their thinking will be different. Give them emotional support. Be cautious when they are walking, or don't leave them unattended. Don't leave them alone. They have a history of frequent falls. They can break their head, they can break their thigh, their limb bones. So don't leave them unattended. Slips and falls are very common in elderly. Vision issues are there in elderly. Uh, Even the slightest infection in elderly can be extremely fatal. That can lead to sepsis, example, a urinary infection or a pneumonia. So if they have any slight infections, also consult your doctor immediately. Do your blood test like CBP, do your cultures, start them on antibiotics if required, as suggested by your doctor. Elderly people may not mind not have fever all the time, but they may be sick with infection. Because to mount fever also, you need to have immunity. They may have low immunity. So don't take things lightly. 3 or 4 loose motions also, they can get very dehydrated. So every small thing in an elderly has to be assessed with lot of caution.
So, sir, can you summarize this entire session for us today?
See, geriatric oncology is a very, very, very specialized field. You will see that day in and day out. And as I tell you, it is not just about they have to be treated and they have to be dealt with differently. You have to give more time to these patients because they want that much comfort and care from you. And mentally, spiritually, physically, they have emotionally, they have to be in a good place. And many a times they also have a feeling that I have lived my life, I want to die. What more in life? Why treatment? Why diagnosis and all that? So if your treatment will definitely do something good for them as far as their health is concerned, then I think you should sit, explain to them that why you are doing this, how it will help them. Uh, and most important emphasis should be on their quality of life, not how long they live, but how well they live.
Okay. So, would you elaborate a little bit on the second opinion campaign which is being run by you?
So, as you know, we are all running a second opinion campaign. We want to reach out to people who are, what do you say, who are in a dark about how to deal when they have a diagnosis of cancer of somebody, of some loved ones or friends or someone. Do you have a mobile number? You can reach out to that by sending a WhatsApp. Send your reports. We'll see that and we'll text you back. You don't need to pay anything. This is just to give you a guidance on how you to go forward. And you can obviously show it to a nearby oncologist, whoever is there next to you, and you can take treatment. There is no hard and fast rule or compulsion that you need to come here. Basically, an initiative that we want to share our expertise with people who are definitely in need and for whom reaching a specialist may be difficult and who think that they have to, or if it is financially not possible for them to reach out. So, this is a completely free service where at least a basic opinion once or twice we can give it to the patient and their family.
Thank you for enlightening us on today's topic on geriatric oncology. And we hope to see you again in another great topic to discuss on the next session. Thank you, sir. Thank you
Thank you.
for your time.
Bye. Bye.